Hello, my name is Lisa Licitra. I am the director of the Medical Oncology Head and Neck Department at Istituto Nazionale Tumori in Milano. Today, it's my pleasure to welcome you to this discussion of navigating the challenges in the treatment provision in recurrent metastatic head and neck squamous cell carcinoma. I'm not alone today. I'm joined by Dr. Aline Chavez from DOM Oncologia Brazil and Professor Joël Guiguet from Centre Antoine Lacassagne in Nice, France. So welcome to the faculty and welcome to all of you. Today's agenda is we will go through these points. What are the key data informing the treatment of recurrent metastatic head and neck squamous cell carcinoma? How do the latest data translate into treatment decisions in clinical practice? And how can patients' priorities be established and incorporated into the care plan? Now we move to the first session of our meeting. We will be discussing about what are the key data informing the treatment of recurrent head and neck cancer patients. We do know that there are some chemotherapy regimens for the treatment of first-line head and neck cancer patients. The first one is the extreme type of regimen, which is made of platinum 5-FU plus cetuximab, followed by weekly cetuximab maintenance till toxicity or progression of disease. We know that extreme provides an increased median overall survival versus chemotherapy alone. However, extreme is associated with many toxicity, mainly due to the combination of chemotherapy. A second type of regimen is the TPEX regimen. This is a combination of cisplatin, docetaxel plus cetuximab, followed by cetuximab every 2 weeks at maintenance. We know that TPX led to non-inferior overall survival versus extreme, and it was shown to improve overall survival when TPX was followed by immunotherapy as second line. We also know from the study, the TPEX study, that there is a favorable side effect profile and it improved quality of life versus extreme. What about the new data emerging from the use of immune checkpoint inhibitors for recurrent metastatic head and neck cancers in first-line setting? These data are based on the KEYNOTE-048 trial, which randomized patients to receive either pembrolizumab alone or a combination of pembrolizumab plus chemotherapy based on 5-FU and platinum or the extreme regimen. From that trial, we got that pembrolizumab monotherapy was non-inferior in terms of overall survival in the total population versus extreme. And we also understood that pembrolizumab plus chemotherapy is superior in terms of overall survival in the total population when compared with extreme. Both pembrolizumab monotherapy and Pembro plus chemotherapy proved to be superior for patients with CPS equal or more than 20 and for those with CPS equal or more than 1. Pembrolizumab, in addition, as monotherapy, had a very favorable safety profile versus extreme combination, while the combination of chemotherapy plus immunotherapy had a very similar toxicity profile as extreme. What about the immune checkpoint inhibitors for recurrent and metastatic head and neck cancers in the second-line setting? This approval of 2 drugs were based on 2 monotherapy trials, basically with the same type of design. Okay, so now we can move to the discussion with Aline and Joel on these topics. And I would like to start with a first question that I would like to pose first to Aline and then to Joel. What are the conclusions that can be drawn regarding the use of different chemotherapy regimens for patients with recurrent head and neck squamous cell carcinomas? Give us your view, Aline. Thank you.
Thank you, Dr. Chitra. I think the main conclusion is we do have an overall survival gain when adding cetuximab plus chemo or pembrolizumab plus chemo. But I think it's essential to treat the patient in the right moment, with the right profile, and with the right drugs. Furthermore, chemo is important for the response rate, as we see, and either adding to cetuximab or to pembrolizumab. I think it's my main point.
Joel?
Yes, I agree with Aline. I think that, of course, we need to focus of the aim of a treatment, so to adapt to the patients, to the variety of patients, of course, and to also to be aware of about the potential toxicities of our treatment. And I think that we will talk about it later. But for us, following the TIP Extreme trial, so we have now more experience with taxane and cetuximab, such as the TIPEX regimen. And so in France, we moved from extreme to a TIPEX regimen for fit patients, of course. And it's not possible in all centers because taxane are not reimbursed for all the centers, but for most of cancer centers in France, we can use TPEX or for fit patients if we don't use a combination of pembrolizumab plus platinum plus FaviFu. So our concern is about the use of FaviFu as we know that our patients may have many comorbidities, and FaviFu is not easy to deliver, and with some contraindications, and we need to do the TPD before. So we the idea, of course, would be to combine taxane and immunotherapy, but we need to prove that that's the best way.
Okay, if I remember well, Joel, the TIPEX regimen was based mainly on 4 cycles, correct?
Yeah. Yes.
So this might be also an aspect that should be considered when, in terms of toxicity and prolongation of treatment.
We demonstrated that 4 cycles seems sufficient, and with only 4 cycles, we decrease, the total dose of cisplatin, and so we decrease also, the toxicity related to the cisplatin. And so I think that's a very important point, and to maintain, the quality of life, the general status of patients, and maybe to be able to deliver a second line treatment or maybe more. So I think it's also very important, yes, to keep in mind. And we use also, GCSF support. That is very mandatory with TPEX.
Okay, so thank you, Joel, for your very knowledgeable thinking about the TPEX study. So I would move to a second question, which has to do with the new drugs that appeared in our scenario, in the head and neck scenario. So what does the clinical trial data show regarding the use of immune checkpoint inhibitors, alone or with chemo, for patients with recurrent metastatic? Is this a breakthrough? What do you think, Aline?
As you mentioned, we now have level 1 evidence from Keynote 48. that either Pembro mono or Pembro plus chemo extends survival compared to older standards of care such as stream or PETs. But it's essentially true in patients whose tumor express PD-L1. I think we should consider uh, options for patients with CPS and 1 and for patients where contraindication to immunotherapy exists. And this we should use an extreme or I prefer TPEX2 here in Brazil.
Joel, which are your
Yes,
thoughts about immuno?
of course, you know, the immunotherapy change a lot. As for lung cancer, you know, our practice first in second line with nivolumab, it's clear that that's our standard in second line if patients do not receive, you know, IO agent in first line. About the first line, of course, as we, according to our experience with Avifu, where in case of need of rapid response, you know, for patients, we still prefer to use a TPEX regimen in France in first line, according to the results, of course, also, but we need to confirm it. But the very promising results of IO immunotherapy after TPEX maybe with I remember that with a median overall survival of 22 months. So the sequential treatment in my mind is a very important point and unsolved point, and I think that would be very important to start trials to compare these different you know strategies. But in clinical practice, as I said, we focus on the level of the threshold, as Aline said, of CPS. Of course, we know that the patients with a high level of CPS benefit more from immunotherapy, and so the question of the immunotherapy alone is important to be discussed for patients who can receive it and without a fast growing or with a high risk of complications, you know, for the disease. And so for patients who don't need, you know, a rapid response, I think that for patients with a high level of CPS, we can, with a close follow-up, propose to them pembrolizumab alone. For the other patients who are less, you know, comfortable, you know, for patients with CPS less than 20, between 1 and 20, I think it's as for lung cancer, we propose for most of patients a combination, and so we discuss between TPEX or pembrolizumab plus platinum plus 5-FU. It depends on the centers and the experience of physicians. But at now, as we have no, we lack of a large experience on pembrolizumab plus platinum plus 5-FU in at least in France. And I would remember, of course, that for CPS less than 1, the pembrolizumab is not reimbursed, is not approved in France and in Europe also.
Yeah, clear. Yes, thank you, Joel. I think we will have time to discuss this further because it's a key question. What should be decided and which are the reasons for deciding one or the other approach?
Yeah, so one important point it's access, isn't it, Professor Joel? It's access to the drugs, to the IO or to the cetuximab plus chemo. In general, this is an important point to discuss, to have access to the treatment, either IO or either cetux plus chemo.
How do the latest data translate into the treatment decision in clinical practice? We were starting already before in alluding to some of these aspects. So I think that here we may make two general points about how to make a treatment decision for our patients. So there are disease characteristics, for example, the tumor site, where it is located, for example, tumor burden, disease aggressiveness, which has been called also as disease pace, platinum sensitivity or resistance, which is also a point that might be worth discussing about this issue about sensitivity, PD-L1 expression. Then there are for sure also patient factors, also family factors, as functional status, the presence of comorbidity, symptom burden, treatment history, contraindication to specific drugs, such as, for example, for uracil or the continuation of cisplatin, and not to forget about patient wishes. So I'm back to you, Aline, and asking you, how do you decide in your clinical practice? Which are the main points that you are looking at before making a decision and discussing with the patients?
Yeah, I think if you would design a flow chart, I think the first line should be the PD-L1 marker analyzed by CPS, as you mentioned. If positive, higher than 1, I think we should consider IO plus chemo. When CPS is higher than 20, we may prescribe either IO mono or IO plus chemo. The decision should be based on tumor burden, symptoms, age, performance status, comorbidities, and of course, IO contraindication. But the gray zone is CPS between 1 and 19. In general, I would prescribe IO plus chemo, but for some patients, mainly patients with high tumor burden, tumor at risk of obstruction, I think I would consider chemo plus cetuximab. And for patients with CPS lower than 1, I think we should be prescribed cetux plus chemo, and after tumor progression, consider IO in second line. And in the second line scenario, after IO in first line treatment, I would prescribe cetuximab plus weekly paclitaxel. We have good retrospective data showing the efficacy of this protocol with a high response rate.
Joel, how would do you agree with this algorithm, decisional algorithm of Aline?
Yes, yes, I agree. We follow the same algorithm. We published recently, quite the same. We of course we are taking account into account the PD-L1 level and also the aggressiveness of the disease. So is there a need for rapid response? I think it's very important, especially for patients with only local regional relapse. So I think that's a point which is not clear. We of course we need to be cautious about subgroup analysis, but I think, and according to our first experience, it seems that patients with only local regional relapse, especially with a big relapse into the neck, would have a response, the decreased response compared to the other patients. I think it's very different, between a patient with a lung metastasis and with a local regional relapse with a high risk of complications. And in our first experience, it seems that these patients respond less to immunotherapy. And it's clear that these patients should not receive immunotherapy alone in my mind. And the second point, that if we decide to treat these patients with pembrolizumab alone in first line, we need to follow up very carefully these patients during the first month in order to verify that the treatment is efficacious, and to avoid any hyperprogressions or progression of a disease, in order to switch to a chemotherapy-based regimen to control the disease. So that's our point. But as I said, if we need to choose between extreme and TPEX, we decide according to the general status of patients. And for fit patients, we prefer to use TPEX if we need a fast and response, in first line, of course. In second line, we use nivolumab in second line. It's approved. Pembrolizumab is not reimbursed in my country. And if we treat the patients with immunotherapy, pembrolizumab plus alone or chemo, there are no clear data about it. And we lack, some trials, and evidence-based medicine. But as Aline said, in routine practice, we use paclitaxel plus cetuximab in second line for patients who progress, under pembrolizumab maintenance in second line.
Thank you, Joel. Let me ask Aline about a favorite combination that she might dream of, namely, let's suppose we are speaking about mainly about first line treatment, and you are often referring to fit patients, but we know that unfortunately some of these patients are not fit enough, but they would need a response because maybe the disease is at the local regional level, for which we need a response. So let's suppose that you would like to put together with a CPS positive. I guess that you would like to put together immunotherapy with chemotherapy, but you are seeing patients and afraid patients and unfit patients. What would you put together if you would be able to do so?
This is a good question, because I think for CPS negative patients, we use cetuximab plus paclitaxel, weekly cetuximab and weekly paclitaxel. But I think we cannot do that with IO plus paclitaxel yet. I think we need to wait the P10 study, because it's not the same drug, and we don't know the safety of the combination of platinum plus taxane plus IO. I think we need to wait that. And to answer you, I think we need to combine. If I use IO alone, Pembro alone. If I don't need a fast answer, a fast response, but if I need to put to chemo, I try to platinum plus IO and don't use 5-FU.
Are you allowed in Brazil to do that?
No. Yes, I can avoid a chemo. I cannot put chemo.
Okay.
Yeah.
Okay. And with you, Joel, would you be allowed to do so?
It depends on the center,
Okay.
I would say that in cancer center we are more flexibility. It's different, in private centers, and we are more, yes, in cancer centers we are allowed to do it. A question is, can we use pembrolizumab plus carboplatin alone? That's a question for elderly patients.
Yeah.
And we wanted to start a trial, we are waiting for the approval, but we have asked, to the authorities if it could be, approved, because I think it's important, and for maybe even for unfit elderly patients.
Yeah.
So, and we use PCC, paclitaxel, cetuximab, and carboplatin, weekly paclitaxel and carboplatin, as Christian Borel, developed, this regimen, and for unfit patients, it seems feasible, but and so yes, we can do it, but of course, I think that is not allowed in all centers in every countries. So I agree, but in my mind, the combination of taxane, IO agent, and cetuximab for me would be the best combinations, and to adapt to the variety of the patients, and so to release one drug or not. Of course, the ideal would be chemo-free, a chemo-free combination. That would be, maybe the future we are waiting for.
The next session will be about how can patients' priorities be established and incorporated into the care plan. So just how we as clinicians, we should be aware of patients' preferences and priorities. It's not always very easy to elicit preferences and to know about the priorities of our patients, but clearly there are factors that can influence their well-being, and we have heard about life-threatening complications, as said before, the presence of severe symptoms such as pain, nausea, constipation, malnutrition, sleep disturbances. I would say also swallowing problem, also dyspnea, for example. I would also add as factor that influence patients' well-being is the presence or the absence of a caregiver, and clearly the life expectancy, which is expected in given cases, which might be of weeks. So this is something that we do have to take into account when taking these preferences and priorities of our patients. There are also effects on psychological effects of these situations, such as psychological distress, social isolation that we know very well. There is a compromised quality of life, and there is also a high suicide risk. That is something that we know from the head and neck cancer population, unfortunately. To address these issues, we may work to understand treatment expectation from the patient's point of view. And I think that here there is a great big work that is also done in the elderly population by the French group that Joël knows very well. We should be aware of different type of communication styles and how patients cope with informations about their disease status. And we also have to consider the level of health literacy, which might be very different, and especially in head and neck cancer patients might be particularly low. And clearly, we should be able to try to balance patients' desire to prolong survival with their need for a good quality of life, especially when we think about the future, the expected future, the immediate expected future for these patients in the recurrent metastatic setting. So again, I would ask Aline and Joelle, how do Aline first? How do you cope with this? I would say these are all challenges that are posed to oncologists dealing with head and neck cancer patients. And although we know that we are not alone because we are normally working in a multidisciplinary framework, we are often left, I would say, alone in some basic decisions because they are asking us about the prognosis, Okay, Aline, go ahead. That's for you.
Yeah, I think it's essential that treatment options for patients with recurrent head and neck cancer be approached in a holistic manner with individual priorities and preference in mind. And we should focus not only on their survival results, but also on patients' needs, wishes, expectations, and quality of life. And it's critical for us oncologists to listen to what patients are saying and maybe not saying during treatment decision-making conversation. This is my point of view in this topic.
Joelle.
Yes, I agree with Aline, of course. Especially in this setting, I think it's very important to listen to the patients. It's not always easy, as you said. I'm not talking about laryngeal cancer, but I would say that we face two different patients. Sometimes patients who are isolated, with smoking and alcohol habits, and so it's very different from, for example, for a young patient with oropharyngeal cancer, HPV positive, with an active life, So we need to adapt, and of course the expectations of these different patients are very different according to the age, of course. And it's, in my mind, it's very important also, for example, elderly patients, older patients, what they expect from the treatment, and sometimes they prefer not to be treated with chemo, for example, and to preserve the quality of life. So I think it's very important to discuss and to keep the time, to listen to the patient and to discuss with him and the family before starting a treatment. As we said, also, it's very important to identify what the patient expects for treatment, and often is to release the pain, and to be able to swallow, and I think that's a very important point, and sometimes before the survival.
Yes, I think this is a very good type of approach. My question to you is: since immunotherapy is so well tolerated, has this option changed your well tolerated, and often we are not able clearly to understand, to predict whether this drug will be helpful or not, because we know we do have PD-L1, but it's not sufficient for us, because we know that even high PD-L1 expressors may not experience a response. So the fact that we now have these immunotherapeutics, which are so well tolerated, with an unpredicted somehow way of of response. Has this changed your way in which you speak with your patients, Aline?
Yes. Sometimes I tell the patients about 30% of the patients are alive in 4 years in the keynote 048. And the data from TPX, IO after TPX, 22 months alive. I think when discussing with the patient, we need to give some perspective. What this chemo can add to their life, not just how long my life will be, but how the life will be. And this is the main point for me. And we have good data with IO in first or second line, and with cetuximab in first or second line. I think nowadays I talk to the patients about this data, this perspective data. It's a good data.
Joel, has this changed?
Yes, of course, especially in second line in my mind, because I think it's of course the nivolumab is well tolerated, of course, and with better efficacy. So now it's clear that it's not difficult to propose and to decide to treat the patients in second line with nivolumab alone. It's clear that we may have a prolonged survival, and progression still is, of course, median PFS is always 3 months under nivolumab in the real life, but we have patients with a prolonged survival with a good quality of life. So of course, it's very different compared to chemo, and that's changed a lot in my mind in second line. In first line, as we said, we focus on the level of a threshold of CPS. If a CPS is very, more than 20, and of course, according to the good tolerance of immunotherapy, we prefer to propose to the patients in case of no need of rapid response, of course, a treatment which is largely better tolerated than chemo.
So I would like to close this interesting meetings by thank you all the participants for watching the discussion about navigating the challenges of treatment provision for patients with recurrent metastatic head and neck cancer. And I really hope this has been useful for all of you. Thank you very much.